Hello, everyone, and thank you for joining us today at the next in the series of our Lunch and Learn series on best practices in conservative management of scoliosis. On behalf of the co-director of our center here at Prachi, we'd both like to welcome you to our ongoing series. We have two amazing guests today, and I'll just quickly thank my partner and friend, a scoliosis expert here in the department, Dr. Zeeshan Sardar, for joining us and taking the time, and my friend and colleague Beth Taranova, with whom we've worked together for so many years, taking care of patients with scoliosis. So I appreciate both of your partnerships and time today. And as people are logging on, just a couple quick comments. First of all, I want to congratulate Prachi. I think many of you were at SOSORT recently, and I think many of you know that Prachi was nominated to the board of directors of SOSORT. So it's an amazing honor, but also an honor that's so well deserved because of all your contributions. So for the 100 or so people online, I know you're all equally celebrating the next phase of leadership and governance in this space. And it's an honor to work with you in this capacity, Prachi. Congrats.
Thanks, Dr. Vitale. That's very kind.
SOSORT was awesome. I was between two different meetings that week and unfortunately didn't make it, but my partner Benjamin Roy did and presented some great work looking at curve flexibility. I think as we're all trying to get better in this space, we're understanding that we need to better understand curve flexibility as a critical determinant of bracing and physical therapy success. So if you have not seen that, please take a look at it. Ben's been particularly involved in this conservative scoliosis space, and he is now leading both the pediatric spine study group's efforts and the harm study group's efforts around developing specific registries for conservative scoliosis. This is obviously long overdue, and I'm excited to see Ben take a position of leadership here. Other updates, I was at ePOSNA, the combined meeting of the European and North American Pediatric Orthopedic Societies just last week. It was the largest collection of pediatric orthopedic surgeons ever assembled in the world, a great meeting in Washington, D.C. My friend and partner, Larry Lenke, gave an amazing keynote about life balance. And we had a number of presentations as well. One of my favorite presentations was an update on the work that we're doing on outcomes in three-dimensional bracing. We all understand the role of frontal plane correction in the brace, but this was an update on a group of patients where we did 3D reconstructions in the brace. And there's some really amazing results. For example, we showed about an 8 times odds ratio of success or failure in the brace, depending on what we are doing to sagittal plane. More specifically, in those patients with a high pelvic incidence, when we're mismatching or taking away their lumbar lordosis, the brace is relatively ineffective. This is, I think, going to be groundbreaking research. We are now 51 out of 160 patients in a multi-center study with CHOP, Nemours, Boston Children's, that's very carefully looking at compliance and 3D correction, which I think is really going to reset the standard for best in practice bracing. So I'm really proud of the work of my amazing team here and all the good stuff that's happening. And I think when speaking about amazing team, I'm going to pass it off to Amber and Prachi to just give you an update about some other exciting things on the horizon before we kick off the webinar.
Great. Thanks so much, Dr. Vitale. So today we are very excited to host Dr. Zeeshan Sardar. He is a colleague and friend of ours, and he works, so much in the entire pediatric adult orthopedic space. And we've also been doing a lot of pre-op strength training on a lot of his patients. So we're really excited to hear what he has to say. And then, of course, if we're talking resistive training, we had to invite the none other than Beth Taranova, who has revolutionized and just pushed just the overall promotion of wellness and then the benefits of resistive training specifically for this population. I want to touch base on our next Lunch and Learn, and this is a great opportunity for us to announce that we're having an incredible team member joining our group. Dr. Smith is joining our practice as of September, I believe. And he also chairs the non-operative branch at SRS. And we've asked him to talk about how we can do better in the research space, because I think that is where we can make a big impact. And then I think that will help everything else snowball from there.
Yeah, thanks, Prachi. We're so excited about having Brian on board. He practiced as chief of peds ortho at Yale, and then as the chief of orthopedics at Texas Children's Hospital. He's now moving back home, and he'll have an entirely non-operative practice. It's an amazing opportunity to really push even harder in this space. So we're really, really excited. He's going to be a great part of the team. Please don't miss the next Lunch and Learn. Brian has so much to share with you.
And then finally, we have an official hybrid date, meaning in person and virtual. It's our 10th annual, if you can believe it, our best in class symposium on the non-operative management of scoliosis. It's going to be September 26th. There will be more details to follow. The agenda is almost finished, and you'll be receiving registration information that goes along. So hopefully everyone can join. Hopefully in person, definitely virtually, and every year seems to be better than the last. I'd like to give the board back to start with Dr. Zeeshan Sardar. Thanks again.
Thank you. Thank you very much, Prachi and Dr. Vitale, for inviting me. Give me a second. Let me just share my slides. All right, do you guys see this here? Okay, perfect. All right, so I was asked to talk about adult scoliosis and when we consider surgery and some of the reasons that we do not consider surgery, and then also a few options in terms of surgical treatment. And then I think Beth will touch upon the role of physical therapy in this as well, so I won't go too much into that, but I will show you guys some cases there too. So just to begin with, so we all understand, a normal spine is supposed to be quite well balanced when we look at you from the front or from the side. So in both planes, coronal and sagittal. But any deviation in these different planes can exist and can cause an imbalance in the spine, and sometimes that leads to symptoms. So that can happen in the coronal plane or in the frontal when we look at you from the front. That's called scoliosis. Or if you look at patients from the side in the sagittal plane and the alignment is not appropriate, then that could be due to kyphosis or hunch, or lordosis, having too much of a leaning of the spine backwards. And then we have rotation as well. So a few different planes where the spine can exhibit a deviation from the normal. And so just to show you a spectrum of what these kind of conditions can encompass, we have the most common type in the adult world is degenerative scoliosis that we see, but a close second to that, and sometimes actually that becomes more common depending on the practice, it could be idiopathic scoliosis, which is essentially the younger people who had scoliosis as a teenager and now are becoming more symptomatic as an adult. And then we see other causes of scoliosis that can include congenital or someone who had a prior trauma or tumors, or sometimes prior surgery can lead to this as well, and a few other rare causes. And just to highlight the different spectrum here, this patient here is someone who I would consider has an adult idiopathic scoliosis, meaning someone who probably had a scoliosis as a teenager and just over time either has become a bit larger than it was or just became symptomatic from that. The second patient here is a patient, an older patient in their 70s, but with kyphosis. So you can see the upper part of the back is really hunched forward, related to osteoporosis, making it difficult for them to stand upright. The third one here is a typical, more of a degenerative type of scoliosis, where over time arthritis or wear and tear of the spine leads to scoliosis, and typically that's seen more in the lower back as opposed to the thoracic in the idiopathic ones. And then we have people, patients who have either syndromic or connective tissue disorder, and some of them do become more symptomatic in the adult age as well. And the last one here is a pretty unique one, which is a patient. This is not a trauma, but this spine is essentially dislocated. This patient had neurofibromatosis and presented to us with this essentially dislocated spine that happened gradually over a period of many years. And so why do adult patients seek treatment for their scoliosis as opposed to the young population? So, and one of the most common causes for these patients coming to us is really because of pain. It's because now they have worsening back pain or leg pain because of degeneration or stenosis or nerve compression. The second most common reason, especially in the younger adult population, is patients are coming in because they're noticing a change in the shape of their spine or their trunk. And they can also have then concerns about what happens to them in the future implications. So that's a big concern for these patients as they see things are getting worse with time. And less commonly, but we still do see that, is dissatisfaction with the appearance as well as cosmesis. And lastly, pulmonary limitations, but those are not as common. And so, I just want to go over a little bit of evaluation of what we do with these patients before we get into how we treat them. And so, like anyone who comes to our office, whether young or old, the start is really with the clinical evaluation, getting a thorough history of these patients, trying to figure out why they're here, what's bothering them. Is it the pain? Is it the back pain, leg pain versus the scoliosis or kyphosis or the imbalance of the spine that's causing them issues, whether they have weakness in their arms or legs. And so essentially trying to get a good understanding of why they're here. And then the second step is examining them, getting a good physical examination of these patients so that we can really see what kind of problem their spine is creating for their balance as well as for their appearance. So we do try to get a good idea of their spinal shape. So as you can see, we have them assessed appropriately in standing, as well as often we'll get them to lie down on their back and the front to really see how flexible the spine is. And we have them walk, and especially in the older patients with leg pain, we're trying to understand if the pain is related to their back or is it related to their hips or knees, or even sometimes from a vascular problem that can cause leg pain. So that's part of the physical exam. And to quickly move over to the next step, this is the radiographic examination, where we have to make sure that we get a good assessment of their spine in multiple planes. So we want to look at them from the front, we want to look at them from the side. We want to be able to get at least the spine, but from the cranial, so from the ear almost to the hips, to make sure we get a good idea of the spine part. But ideally now more and more we get this EOS imaging, which includes the whole body, because we know that spinal alignment can be affected by the legs as well, and the legs can affect the spine. So it goes both ways, and so that's why it's important to really see the patient in a full standing X-ray. And then we get flexibility films, which is in most of the cases now for adults, we get supine film. So we have them lay down and get an X-ray that way, and you can see this patient on the left-hand side is standing, and on the right-hand stand is laying down. You can see a big difference just from going from standing to laying down in terms of what the shape of the spine, how the shape of the spine changes. And then CT scans. People always ask me, why do you need a CT scan if you have an X-ray? Or why do you need an X-ray if you have an MRI scan? Or why an MRI if you have a CT? So I just want to quickly highlight the changes. CT scans are really useful for us to figure out what kind of bone anatomy we are dealing with. And as you can see in this patient with scoliosis, in the middle of the scoliosis, that spine is automatically fused. So it's important for us to understand where the spine is fused. It's important for us to understand where the degeneration is. Patients who had prior surgery, it tells us if they're healed or not, and if the prior instrumentation is in a good position or not. And then the MRI scan is really critical because it shows us how the nerves are being compressed or affected by the scoliosis, and especially for older patients who come in, they can have a lot of nerve compression or stenosis that is causing the symptoms. And depending on the type of procedure they may get, we look at their anatomy, vascular anatomy, and anatomy of the muscles as well, to see which approach will be good. And as you can see, we often will get 3D reconstructions of these patients to really try to understand the alignment of the spine and what's happening with the spine in a three-dimensional manner. And then, this is patients. Patients are obviously interested in knowing the degrees of curvature and everything. So we do measure the different alignment parameters, again, in the frontal plane and in the sagittal or side plane. And without getting into too much detail, this is just an example of how we try to assess how balanced or well-aligned a person's spine overall is if we look at them from the front or from the side. And then we also obviously measure the scoliosis. But as you can see, the scoliosis is in different parts of the spine. It can be in the proximal thoracic or the very top part of the thoracic spine, in the middle part, in the lumbar spine, and at the very bottom in the lumbocervical curve, which becomes a lot more important in the adult populations because often the pain is coming from the lower part. And so just to give an idea of how significant this problem is for the adult patients who have scoliosis or kyphosis, this was a study published some years ago now. It's well known now, of about close to 500 patients with spinal deformity or spinal alignment problems. And they compared the disability that these patients had with the disability of some of the other common diseases that we know of, including diabetes, rheumatoid arthritis, and even patients who had amputations of their limbs. And you can see that the patients who had the lowest function or the most disability were actually patients who had spine malalignment, making it difficult for them to stand up. So even compared to some of the other diseases that we know of, these spinal alignment problems can present a lot of functional disability for our adult patients, especially as they get more and more decompensated and they lose their strength. So this really highlights the significance of this problem that we're dealing with. When do we, so again, most of the conditions in adult patients, we try to treat them non-surgically. And so there's a very small subset of patients that eventually ends up getting surgical treatment. So the question is, well, why do we decide on surgery for some of these patients? And the most common reason ends up being a failure of non-surgical treatments. For patients who have done a lot of physical therapy and have tried, medications or sometimes injections and still continue to have a lot of pain because of a well-identified problem, structural problem in their spine, typically that's when we start to think about surgery for these patients. Or it's in patients who have significant imbalance of their spine and are seeing that their alignment is rapidly worsening with time. So those are kind of the common things that reasons for getting surgery. In terms of options for surgery, there are different options. There are small surgeries and then there are big surgeries. At the very end of it, the bigger surgeries mean that we are going to essentially, with surgery, treat the whole scoliosis or kyphosis or the alignment problem. But on the smaller side of things, sometimes people coming in with a leg pain may need something as little as a small decompression. That typically can be done as an outpatient surgery as opposed to a much bigger surgery. And then there are options in between where we don't need to fix the whole scoliosis, but we may figure out exactly where the problem is and then just focus on that small part to address the pain. So it really depends on again, taking a good history, physical examination, as well as matching everything with the X-rays and MRI scan and all that. Now, Prachi had asked me to also talk about what kind of things we look at before surgery in terms of optimization. So I want to spend a couple of minutes just talking about optimization here. And we had recently published on this very topic, essentially looking at all the different things in adult patients that potentially are modifiable and can be optimized prior to surgery. And so the major categories here are patients with osteoporosis, so if we have poor bone health, obese patients, patients with diabetes, patients with poor nutrition, patients who take a lot of opioid medications, those who smoke, and also mental health. Mental health is extremely important. We can't forget that, so we do screen our patients for that. Patients who have, we assess their social support mechanism as well. So we do look at all these factors for our patients to determine if there are different things in here that can be improved before the patient has surgery, so that we can really optimize their outcomes. And so we also, in the same paper, then published recommendations for all the different issues. So if you have osteoporosis, or if someone is suspected to have osteoporosis, and we assess their bone health prior to surgery, and some patients we actually have them take medications for anywhere from 3 months to 6 months prior to surgery to strengthen their bone before we operate on them. And similarly for everything, for patients who we feel can improve their functional status, can really strengthen their muscles or improve their endurance. Prachi sees a lot of my patients pre-op to work on this so that we can again improve their outcomes from a physical perspective as well. Obese patients or patients with diabetes, we work on their nutrition as well as getting their weight under better control. Smoking, if you're getting surgery for scoliosis, and if it's not an urgent surgery, essentially you have to stop smoking because it's known that it has a lot of other complications. So I'll go through some of these a little bit more. We published guidelines actually on bone health optimization prior to surgery as well. And so all of my patients over the age of 65 and those between 50 to 64, if they have any risk factor, we will assess their bone health and we'll put them on treatment prior to surgery so that, again, we get a better outcome from a surgery perspective. Like I said, smoking, vaping, chewing, nicotine, any kind of nicotine products, they have to be stopped for at least 3 months and up to 1 year after surgery. Why do we do that? Because we know that this interferes with the healing of the bone and also increases the risk of infections in our patients. Pain medications, chronic pain medications such as opioids is a huge issue. And again, it's well researched that these patients have a higher risk of infection, needing more surgery, readmissions, reoperations, and even overdose after surgery if they're coming in with chronic use of opioids. So we have our pain management team work with these patients or the local pain management physicians, try to come down on these before we do surgery. A preoperative rehab is extremely important. And the best kind of comparison I can tell my patients is, these surgeries for scoliosis can sometimes be major surgeries. And you have to think of it like preparing for a marathon. You don't just get up one day and you run a marathon. You have to prepare for it. And so I think surgery is the same way. So our patients, I tell them they have to start working on their strengthening endurance exercises for a few months, 2 to 3 months before surgery, so that they're well prepared, so that they're coming in strong and their heart is in a better shape to tolerate the stress of this major surgery they're going to undertake. So we published on this recently as well. Prachi was a part of this, on the importance of prehab before surgery. And nutrition, we've looked at that as well. We recently published that as well, on the importance of nutrition and optimization of nutrition in these patients prior to surgery. And there are certain parameters we look at to see if a patient is nutritionally optimized or not. And vitamin D, just like in the pediatric population, in the adult population as well, vitamin D deficiency, or I should say insufficiency, is a major problem. A lot of our patients come in before surgery and they don't have enough adequate vitamin D intake. So, we start them on these nutritional supplements as well. And so I think in the last few minutes, I'll just go over a few cases as to when we did surgery or when we did not do surgery, and even some cases of optimization. So here's a 62-year-old female who has, as you can see, scoliosis. You can see that on the X-ray on the left-hand side. She came in finally because of back pain that had been worsening over 4 years. But in addition to the back pain, she also had quite generalized pain in her neck, her arms, her legs. She'd had therapy, she'd had epidural injections. And eventually why she came in was because she used to be on really high doses of narcotics, oxycodone 20 milligrams 4 times a day. That's huge. As well as OxyContin 60 milligrams twice a day, and methadone. So she was on a lot of pain medications. And she eventually comes in. She's not someone who was really that high functioning. And otherwise, her physical examination, she didn't really have any weakness, but she was in a lot of pain throughout the encounter. And this is her pain diagram. This is something I find extremely useful in sometimes assessing, trying to figure out where the pain is coming from. But you can see in this patient, the pain is essentially all over. So arms, legs, back, everything, everything is painful. And the other concerns were high opioid use. She wasn't very active, not because of pain, but that's just her baseline. She's not someone who's very active. And we tried to have her go to therapy to do some rehabilitation, but she wasn't very motivated to do that. She didn't have much family support for post-op care as well. And she smoked, and she wasn't willing to give that up. And so, unfortunately, in this patient, you kind of see that all the pre-op optimization processes we go through, she kind of failed in many of them and wasn't willing to participate in some of them. So we unfortunately could not proceed with surgery because we didn't think that she was properly optimized to have a good outcome. Here's an 86-year-old female with gradually worsening scoliosis over about 20 years. But she didn't really have much back pain. She was very functional. And she actually took care of her son who had some functional disability. And she had osteoporosis. And so these are her x-rays. So now she's 86, but she's functional, no pain. And so, here again, we did not do surgery on this patient because for someone who's 86 with osteoporosis, who can be optimized, but at this point, she doesn't have pain and she's functioning extremely well. And so this kind of highlights that if someone is functioning really well, surgery can't make them better. We can only sometimes decrease the function. So she was quite happy with that. She was just sent here because she wanted to see what was happening with her scoliosis, but she was quite high functioning that we did not think surgery would be a good idea for her at this point, especially at 86. On the other hand, there are patients who do really well from surgery. This patient is 55 years old. She had low back pain and mid back pain, and she had right leg pain that correlated with the nerve compression that she had on MRI scan. She used to be extremely active. She used to go to the gym essentially every day, but for the past year or so, she stopped going to the gym because of extreme pain. And she also essentially was limiting her day-to-day life because of the different pains that she had. So this patient, we did end up doing surgery because she was optimized in other ways. She was very motivated to do physical therapy and participate in the pre-rehab as well as post-surgical rehab. And within a year, she sent us images of her back at the gym as well as skiing on the slopes after surgery. So again, patient optimization and motivation has a large role to play in how they do after surgery. This is a 70-year-old female who had a prior Harrington rod and did well for decades. But over the course of the past few years, the pain crept up. She couldn't be as active anymore. She used to go on long hikes. She couldn't do that anymore. And you can see she's really bending her hips and knees to be able to stand up straight, and she's having a hard time standing upright. And so again, she was someone, I think I'll skip this one, the prior surgery. So she was someone we thought we could help, and just to kind of go over the different technologies we used in surgery. Part of one of this is what's shown here is the robotic technology for screw placement. We plan all these screws then prior to surgery for these patients. We also get a 3D visualization of the screws and plans. This is not her surgery, but someone else. And then we plan rods for these patients. Everything is essentially very specifically planned for these type of cases. The rod is planned, the alignment is planned. And so this patient we did surgery on did quite well, from before to after surgery. You can see standing up quite well now. And you can also see that our plan, which is very specific for the patient, customized, matches our post-op x-rays pretty closely in terms of screws as well as rod and everything and all placement. And she did really well. I saw her, she's out 2 years now. She's back to hiking and all the activities that she used to do because again, she was active beforehand. We optimized her osteoporosis and she was keen to get active again. So she did really well. Here's a 28-year-old female with scoliosis. I did surgery on her. And you can see after the surgery, she was leaning quite a bit to the left side. and we weren't happy with that, obviously. So this is where Prachi comes in. I had her see Prachi. This is after, and I was actually thinking that we may have to maybe revise this patient and try to get her a bit more better alignment. But you can see after 6 weeks of therapy, this patient came in and she was already looking a lot better. And this is after 7 months post-op that she is really perfectly aligned at this point. And so you can see, again, from pre-op to initial early post-op, and then over time, 7 months of doing physical therapy. And again, this is, the patient's motivation, involvement, therapy. Those are the key factors in this patient. She was a young, active mother, and she really wanted to get back to her normal life. And she did really well in terms of her alignment, excellent alignment over time. Here's someone who's 67. I'll wrap it up in a minute. Who had scoliosis, but most of her pain was coming from the base of her spine. So we ended up actually just operating on the base of her spine. She was fused above that automatic. She was auto-fused above that. And so the point here is that not everyone needs their whole spine to be, to do surgery on. If we can localize where the pain is coming from, we can just address that part. And so she also did really well, very happy. She did not want a big surgery. And I think this is my last case. It's an 81-year-old male who I just saw last week, who told me that didn't really know why he was there, but he was sent to see me to just look at his scoliosis and kyphosis. He's 81. He is extremely active. He carries cases of water, bags of salt, lives by himself upstate New York, completely independent, and no pain at all. So guess what I told this patient? No surgery. He's doing extremely, extremely well. And so we'll stop here. The conclusion is, in adult patients, scoliosis is a wide spectrum. We have to match the symptoms with the patient's imaging. We have to tailor the treatment. The patient really needs to be optimized in all sense, and the patient has to be motivated. And sometimes surgery is a great option, and sometimes the patient does not need surgery. I'll stop here, and again, thank you everyone for inviting me here.
Wow, thank you so much, Dr. Sardar. That was wonderful. If you guys are starting to have questions, please put them in the chat box below, and hopefully we can get a really nice discussion going. Next up, I'd like to invite Beth Terranova to talk about the benefits of resistive training and just talk about all of her expertise in this space. Thanks, Beth.
Absolutely. I love speaking on this. Just make sure that this comes up here. There we go. Okay. All right. So talking about resistance training with scoliosis, really my favorite topic to talk about because of my background, a little bit about me. My journey with scoliosis started as a teenager. This is my EOS recently, but just showed you a little bit of me when I was a teen. I think I would have spotted my own scoliosis right away. And I started competing in weightlifting at the age of 15, and I've competed in weightlifting almost over 20 years with no change in my scoliosis curve. But I always had some weird things happen in my training that I didn't really understand. And it wasn't until I became a physical therapist and the great Hagit Berdyshevsky came to my school and taught about Schroth method. And I said, wow, now that all makes sense. So I trained in Schroth method 2018. I've also gone on to train in many schools of scoliosis exercise since then, but I really wanted to share this with others. And one of the challenges I kept running into as a physical therapist was my clients asking me, well, Beth, I love everything we're doing in PT, but I want to go to the gym. What can I do in the gym? Or what can I do with my fitness? And who's the best personal trainer for scoliosis? So finally, I got to the point where I said, well, I have a background in strength and conditioning. I was a personal trainer. Let me just write your program for you. And that was kind of how Strength and Spine started. And since we started in 2020, remember those days, we did the program completely online. And since then, we have continued to work with clients completely online in our fitness and online personal training. And we've learned a lot. We've worked with hundreds of clients with all different curves, surgeries, and we've seen really great results in the benefits of resistance training with scoliosis. So I'd love to share a little bit about what we've noticed, what's important, and some of the practical applications for us in working with people with scoliosis. So quickly, why is resistance training important for people with scoliosis? And there's a few things that pop out to me. One is injury risk reduction, and people with scoliosis do have about 2 times higher the injury risk, as well as reduced quality of life that Dr. Sardar did speak about. And they also perceive their health worse than other people. And knowing that the decrease in trunk muscle mass is a factor for degenerative scoliosis, as well as potentially progression of scoliosis curves. Muscle mass, I think, is becoming more and more important for us in the fitness world, in the chronic health condition world as well. So how can we make sure our clients with scoliosis also have appropriate muscle mass? And we know that strength training has benefits that can address a lot of these things, reducing injury risk, reducing pain, improving cognition, reducing symptoms of depression, fatigue, self-esteem, improving sleep quality, many of these things that we see with our clients that they don't realize how much their fitness affects their day-to-day life. And we know that maintaining muscle mass and bone density is essential. And Dr. Sardar spoke to this very much in terms of looking at potential for surgery. But we know that when people stop exercising, they become deconditioned. And when we think about the relationship of sarcopenia and osteoporosis to scoliosis progression, then we see this cascade that we know is modifiable by incorporating the right fitness program. So in terms of research on resistance training in scoliosis population, there's really not much out there, unfortunately. So really was mainly a powerlifter, a case study that actually the person wrote about themselves, about how they were told not to weight train with their scoliosis, got a lot of nocibic information from the medical field, but then went on to deadlift 300 to 400 pounds, went back to their doctor and said, hey, look, I feel great. My scoliosis didn't progress. And their doctor was like, okay, yeah, I wouldn't have told you to do that, but it looks good. So that's really one of the only weight training with scoliosis research that we have. And a lot of the studies are looking at muscle activation and less strength, although we do have some studies on paraspinal strength with people with scoliosis having less paraspinal strength. So this is something that we do look at, but a lot of the research is focused on the adolescent population with the strength as well. And many of our clients that we meet initially, they get really stuck in their fitness routine or, starting resistance training because they've been told not to lift weights. So I meet with many people who say, well, when I had scoliosis as a teen, I was told never lift more than 5 pounds. So these people end up, really avoiding a lot of exercise because they're concerned about progressing their curve. And they also get a lot of conflicting information online. Social media can be a scary place. There is a lot of mixed information online about what is safe to do, what is not safe, what type of exercises you should do, and in support groups as well. So a lot of times they may start an exercise program that is too fast paced. They end up having more pain or soreness, so they stop. And then they start to worry that exercise is unsafe. Or they do an exercise routine, but it's really not challenging enough for them. So they just do the same exercises for years and years, and they never really develop muscle mass because the program is essentially too easy for them. So knowing about the 3 dimensions of scoliosis and how can we help people with scoliosis to learn how to resistance train properly? So really for us at Strength and Spine, awareness is one of the first steps. So we spend a lot of time on education with our clients. A lot of times they don't even realize that they tend to lean into their scoliosis curve. They don't notice that they are doing that. So for example, this was a client who was already working out in a group class 3 times a week on the left. And when she sent us this photo, she said, "Oh my goodness, I didn't even realize I stood like this." And then the photo on the right was after she had worked with us for 4 months so that she had been able to improve her postural alignment and carry that over into her exercise class. So we talk a lot with our clients as to what factors are modifiable, what are non-modifiable. So for example, if they potentially have some challenges that are more related back to the scoliosis, right? Like very often we'll see that they more have muscle activation on the convex side of the curve. So explaining to them, this is because those muscles are working hard against gravity to hold you up. And we want to work on balancing this to help you for the long term, as well as if they have nerve irritation or tension, helping them to differentiate, okay, this is probably something that's coming from your scoliosis versus maybe this is something that we need to have you go follow up with your doctor for additional imaging and just make sure before we go into a fitness routine. And then one of the first things is really important to get them off what we call to our clients the Scoli-coaster. And this is where our clients, they start an exercise routine. They end up not sure how to progress themselves. Maybe they do too much. They end up hurting themselves or having more pain. So they stop exercising. And then as they stop exercising, they regress. So when they start up again, they end up in that same situation where they try to build back up, they may injure themselves and they have to go. So really consistency, what we found. And it's interesting because we work with clients who only work out maybe 10 minutes a day. For some of our clients because they're so busy, but actually we found that it's more so consistency that we see people be successful with than actually how long or how many days per week they work out. And this is kind of common in the strength and conditioning research that it doesn't matter so much the number of days as long as the volume is equated amongst the workout routines. So it's very interesting. I hope to do research on this in the future to see, how much load do we really need in order to see the results. So in building a consistent routine, really we're looking at addressing different movement patterns. And we found these movement patterns to be very important for our clients. So we kind of break up into pushing and pulling movements. And often the movement, how much we integrate these movements may depend a little bit on the client themselves and what they look like in terms of their alignment. So for example, if we have a client who is hypokyphotic, more flat in their upper back, we may not program as much pulling for them because we don't want to have them go more into that hypokyphotic position. We may actually give them a little bit more pressing or actually a more balanced routine between upper body pulling and upper body pressing. And then in terms of squatting and deadlifting, we may modify these depending on the type of curve that the person has. So we do find that people who have lumbar primary curves tend to be a little bit more sensitive to deadlifts, maybe a little bit more pain with deadlifts. So we have to be very aware and may have to adjust for that person. And then we train core in all different movements. We tend to train core more in a neutral position. Of course, sometimes we will incorporate different core movements depending on the sport that the person wants to do. And I'll talk a little bit about rotation and those things later on. But we try to strengthen them in all different planes because we realize that the core is not just a one motion muscle group. There are many motions that our core needs to stabilize for. And interestingly enough, the weight training in general is core strengthening. Just by moving free weight, your core does have to activate. So they do get a lot out of incorporating their weight training as well. So in terms of warming up, we do, since my background is scoliosis specific exercise, we do incorporate a lot of our scoliosis specific exercise into our warm up. So we do practice elongation. We practice some of our specific activation, influenced by scoliosis specific methods like Schroth, like CIAS, and teaching them how to maintain their alignment as they start the exercise. So we have each of our client, really this is like the foundation of their starting point to really understand their conscious posture, to understand how they can best stack their body when they're exercising in order to carry that over into what they're doing with their weight training. So we get the benefit of now they're taking their postural alignment, they're incorporating it into their weight training, they're training not only their proprioceptive system to more so keep them in that alignment, but they're also balancing their muscles in a more symmetrical way, because we know that we can improve the force production by allowing the muscles to be in a little bit more symmetrical position. So talking about upper body push exercises. So I just gave a few examples of this, like a bench press, like a push-up. We really teach our clients in setting their upper back position. So if they do have a thoracic curve, we will teach them how to level as much their rotation as they can. We do use a small bit of scapular retraction, especially as they're coming down, just to help them maintain a good stability around their curve. Now with hyperkyphosis, so someone who has more of that rounded upper back, we may modify some of this to make sure that they're not going into a more rounded position as they press. So we do teach them how to keep their ribs in a more neutral position. So when they come out of the push-up, they're not rounding themselves more. When we're doing overhead pushing, this is a big question that I get, and often people tell me that they are told with scoliosis not to do any overhead lifting. And we do incorporate overhead lifting with our clients, although we are very cautious to make sure that they have the appropriate overhead range of motion to press overhead properly. So I do a test similar to on the bottom left here to look at if they keep their ribs flat to the ground, can they get their arms completely overhead? And that gives me an idea of their shoulder range of motion versus a compensation at their rib cage. So I'm looking at flexibility versus their control. And I think you'll see a trend as we go through some of these tests that we have to determine, is it a flexibility issue in this patient, or is it that they don't have the awareness or control of their body to appropriately move through this motion? So if I see that they have the appropriate range of motion, and if I see that they are able to maintain a good alignment of their rib cage with overhead press, then I will incorporate that into their program. If they don't have that appropriate motion, I may substitute an exercise where they're in an incline so that they're not pushing fully overhead to still be able to work upper body strength and give them that opportunity, but without overtraining into a position that may give them into some rotator cuff issues, let's say. So this is an exercise that I use a lot of times for people who may have issues with overhead motion. We work a lot of middle and lower traps. So here, basically what I'm cueing is I have a right thoracic curve. So I'm working on the overhead motion of my right arm. I'm using my left arm to push down into the ground and help stabilize through the concave side of my curve. And then I'm lifting the right arm to work into that overhead motion. So that we use this depending on the curve and depending where we're seeing some challenges, we may modify this. For pulling exercises, we talked about doing some horizontal pulling, how we modify for hyper or hypokyphosis. And then vertical pulling is one that I really like. So here I'm showing like a lat pull down. You could do this. Many of our clients like to do this on a machine because when they use the machine, as the machine comes up, it kind of gives them a little bit elongation. It helps them to get their alignment, and then they're able to pull down to create a nice position there. Okay, now we'll get into lower body, because I think lower body is where I get a lot of questions from clients. So looking at the squat is one of the movements that we test in our clients. And we look at a lot of things. We look to see, can our clients maintain a neutral alignment in a squat? Do they have any shifting of the pelvis? Do they have the range of motion that is needed for a squat? And truly, we need a pretty big amount of range of motion in the legs to be able to have a good squat. And we usually recommend that our clients, if they are squatting, to work just below parallel of the thigh to the ground. I don't have them do full all the way down squats unless it's important for their sport. So I compete in the sport of weightlifting. I need to be able to squat all the way down. Whereas my client who just wants to get better at getting in and out of a chair, maybe not necessarily have to do that. So with the squat, we're looking for the hips and the knees bending at relatively the same time. We're looking that they can maintain alignment. We're looking at the position of their torso. And truly, their torso should stay aligned while they're doing the exercise. The position of their torso should not change, although there are different types of squat mechanics. And depending on the client and what type of squat mechanic that they want to do, there may be some modifications in how much hip bending they need versus knee bending. So usually this low bar type squat is more for our clients who are competing in powerlifting. But I also see kind of similar this position in some of our clients that have longer fusions because they have a little bit more trouble getting this upright position, especially if they have some issues with hip mobility. So I will actually see them hinging a little bit more forward like the low bar type squat. So really we're looking for a balance where the client can keep the themselves lined up with their upper back over the midfoot. But also paying attention to making sure they're not leaning forward, they're not changing their torso position. And I think it's been seen a lot on the social media world talking about the butt wink, like when somebody's hips curl underneath them, is it dangerous? Should they be doing that? And there's two reasons why I see people have this type of form issue. One is it's a flexibility issue. So they're lacking the hip flexibility. We need hip flexion. We also need hip rotation, actually hip internal rotation, especially as we get lower into the position of a squat. If someone does not have that hip motion, then they will substitute by rounding their back to try to get lower. The other issue that I see is actually a motor control issue where this person, and often we see our clients with scoliosis are also hypermobile. So they start in a very lordotic position and then they wink because they lose a little bit control of that lordotic position. So again, we're looking at, is it a flexibility? Is it a motor control issue? And these are things important for us to look at. Okay, talking about hinging with deadlifting, many clients are nervous about this because they've been told not to deadlift. Deadlift was actually one of the exercises used in the Lift More study, a very effective exercise to build bone density. So we do want to find clients a way to hinge properly, especially because all day they're picking things up off the floor and they are lifting things. So we want to make sure they're comfortable with that. So we're looking at their hinge. Can they maintain a neutral position? Can they keep their back from rounding? Many of our clients actually do better with a sumo style that I show in the bottom here because they're able to keep their chest more upright and they feel less pressure on their low back. So often we will use a sumo style with the wider stance. Often too, our clients who have had spinal fusions prefer this style as well. In terms of single leg exercises, we're looking at pelvis control and stability. We're looking at hip rotators. Do they have good stabilization there? Do we need to call in hip abductors? So we actually did a small study with my students at Hunter, and we found that people with scoliosis who have pelvis shifts and issues with pelvis alignment often will present with weaker abductors on the side that is shifted. So we do work on our clients to help balance that. Rotation, we really only, we prefer not to use weighted flexion or rotation with our clients. We look at, can we strengthen that in another way? So maybe some static holds, maybe working with the resistance in a different way. We just want to be cautious, especially if they have any instability, to not over rotate with our clients. All right, I'm speeding through because I know we only have a little bit of time. With lumbar curves, core, pelvis, and hip stability are very key. We're monitoring for their rotation. We're looking at their hinging, and we're working on the connection of the lats and the glutes to help stabilize over the lumbosacral curve. For dynamic or explosive movements, they have to master the static movements first. So, if you can't hinge, you can't do a kettlebell swing. If you can't squat, you can't do a push press, right? We have to make sure that they can do that first before putting it into a dynamic activity. So this was a client that we worked with and talking about that stiff versus flexibility. So this client had a pretty significant global kyphosis, but she was very flexible. She was actually able to get herself out of position. So we realized it was more a strength issue. And working with strength training, we were able to get her this result in terms of her posture and actually maintain her bone density for a full year where her bone density had been progressively getting worse. For elite athletes, this is a client we work with who is a world champion wake surfer. And as you can see that, she wanted to incorporate deadlifting into her program, but we had to do a lot of work on form and technique for her, so that she would be able to maintain her thoracolumbar curve well. You can see when she first started, she has a lot of issues with pelvis alignment. She has a lot of rotation through her curve, and we were able to progress this over a few months. So now that she can incorporate this into her routine. Postoperative, we treat any residual curve like we would treat a traditional scoliosis curve. And so that we look at alignment as a piece of that, making sure that they keep their ribs stacked over the pelvis, and making, adjustments for them depending on the length of their fusion. I think I've run out of time, but conversation about pain. If they're having pain with an exercise, we do teach them how to monitor it. We use this traffic light analogy, which I can talk a little more about if there's any questions. Just reminding our clients that they have control, they have options, and it's never too late to get started on our strength training routine. Thank you, everyone. This is a little quick me competing.
Wow, Beth, amazing.
So thank you, everyone, for that.
Oh, that was awesome, Beth. Thank you so much. Thanks for sharing your story and your very inspiring experience. Makes me want to come join you and work on my spine and shoulders.
I was just going to say that too. You have online sessions for us?
Exactly.
Yes, absolutely. Group workouts.
And I can, this combination of two amazing talks really highlights the importance of team approach. I know we are running out of time. Prachi, you want to try to navigate through some of the online Q&As or?
I think maybe we have time for one of the questions. Beth answered a lot of the questions that were already asked for her, and luckily she put in her contact info, so hopefully you can field some of those. This one was regard to that last patient that Dr. Sardar, you talked about, and I have some thoughts on why she was tipping after surgery, and then why non-op measurements helped, and she didn't need another surgery.
Sure. Yeah, I guess it's about the patient who was tilting more towards towards the left side after the surgery, and yeah, I mean, I think we've talked about that in the past as well. The she was 28 and she had a pretty significant scoliosis above. What happens in these patients is that the lower part of the spine is really trying to compensate to keep these patients standing upright. So if you looked at her X-ray before the surgery, that L4 segment was tilted quite a bit to the left side, and the longer what we see is that the longer we've had scoliosis for, or the older we get, the more stiff that bottom segment starts to become. And so again, she was kind of in between. She's 20 years, she's still relatively young, but she's on the older side when we think about our idiopathic patients. So we fused her down to L4, but that bottom curve was stiff. So I think we got some partial correction, but not all the way, because there is some memory built into that bottom portion at this point. And so, the top was straight. So I think that's where, Prachi, really your help. And we saw that within 6 weeks, because again, she's 28. So she's had that L4 that's been tilted for many, many years. And so after surgery, that memory still holds initially. And then, but with therapy and a lot of hard work from, with you from her, really helped that kind of balance that out. That's my thought on that. Well, what do you think?
I wish we could talk more about it. Looks like we're out of time. Jill, who asked the question, feel free to reach out to me. It's about those elusive pelvic rotation and all those exercises. Thank you everyone for joining us today. We're really excited to see you guys again next time. Thank you again so much, Dr. Sardar. Thank you so much, Beth, for joining us. We look forward to seeing you next time.
Thanks.
Thank you so much. Thank you again for inviting.
Thanks to Prajay and Amber for always this amazing organization, and William, who just jumped back on it. We have a great team. Thank you guys very much. Have a great day.
Take care.